Bonsoir à toutes et à tous. Je vous souhaite la bienvenue à ce webinaire de Malaria Pills et Protect the Cure organisé dans le cadre de l'initiative Protect the Cure. Alors, je m'appelle Ramla Amadou et je suis assistante communication à Impact Santé Afrique et j'aurai le plaisir de modérer cette session de ce soir. Merci à vous tous d'avoir pris le temps de vous joindre à nous pour cet échange sur la résistance aux antipaludiques. Good evening, everyone. My name is Ramla Amadou, Communication Assistant at Impact Santé Afrique, and I'll be the moderator of today's webinar. So for all the English speakers, you have the possibility to switch on the icon of a globe that you can just see on your screen to switch for the translation. Et pour tous ceux qui parlent français également, vous pouvez activer l'icône d'interprétation sur votre écran pour pouvoir suivre la transcription en français pour les intervenants qui vont parler en anglais. Alors, je vais poursuivre ce webinaire en français et je vous invite à utiliser l'icône pour la transcription. Ça va se faire au fur et à mesure pendant que nous présentons le webinaire. Les interprètes vont le faire simultanément. Merci. Alors, nous allons sans tarder passer au mot de bienvenue qui sera présenté par le docteur Ito Besson, coordonnateur régional du Sud-Ouest du Cameroun national contre le paludisme. Docteur, vous êtes avec nous? Vous nous entendez?
Yes, Ramla, thank you very much. Can you hear me?
We can
Yes,
hear
I'm
you
getting
very
you
well,
well.
Dr.
You have
Bessel.
the floor.
Thank you very much for joining this, our webinar series. The Malaria Pills webinar series is just an initiative that helps to promote knowledge on the fight against malaria and tackling one problem at a time. And it's a privilege for us to collaborate with Impact Santé Afrique, as well as other colleagues and collaborators on the National Malaria Control Program across the country, and also particularly with Finistec to discuss to you today on very important topic, which is anti-malaria drug resistance. I don't want to mention much because there are other speakers that are going to come after me. They would be really welcome you. We appreciate your time, and we plead that you could also remind your collaborators who are yet to join. Because Ramla, most of the participants of the malaria pills, the frontline healthcare workers, are not very familiar with Zoom. So some of them are getting challenges joining because most of our series are in, we use Google Meet. That notwithstanding, we'll have a very interesting session. We have much for you in package. Stay tuned, and we'll come later to discuss more this subject. Of course, malaria drug resistance is a huge problem. We are here to see how together we can get a solution. Remember, we are driven to end malaria. It means that we're also driven to end malaria drug resistance. Now it's time for us to do that, and now we can actually do that. So thank you very much for joining. I'll give the floor back to Ramla, and I'm sure we'll be coming up again sometime in the session. Thank you.
Thank you so much, Dr. Boson, for these words. Alors, nous allons passer à la vidéo animée de Protect the Cure. C'est une initiative qui porte des messages sur la résistance aux antipaludiques. Donc, nous allons de ce pas jouer la vidéo.
Artemether lumefantrine, also known as ALU or Coatem, has served us very well during this period and has been highly efficacious for almost all malaria cases. This is changing, and it's important that we prepare. We are all very used to having a first-line antimalarial drug. This will change, and we will line drug. So, what does this mean? Let's summarize in a few key points. Number 1, the antimalarial drug we use every years. You may be stocking and prescribing one artemisinin combination therapy, or ACT, but in 2 years, you may be prescribing a different ACT. Different ACTs may also be recommended for different regions of the same country or different age groups in the same region or country. So it will be important to stay up to date with the National Malaria Control Program's recommendations. You should check the national recommendations regularly and also take part in discussions forums, such as online groups of experts, colleagues, and implementers. This will enable you to stay updated about the changes in treatment guidelines and from the National Malaria Program. Number 2, inventory and stock management is now going to take more effort. We will all have to keep up with the national recommendations and know which drugs we currently have in store. And we're going to have to do more planning and timely forecasting on what drugs to order. We'll have to remember to order early, as drug orders sometimes arrive late. Number 3, we will always have to be mindful of appropriate dosage. When drugs change, weight bands change, and we will always need to remember to look up the correct dosage for a patient's weight. Keep all your posters up on the walls. There may be 3 or 4 new antimalarial drugs introduced over the next 5 years. Number 4, talk to your community and talk to patients about these changes. They will have lots of questions, and they will rely on you to reassure them that this is all part of our new approach to fighting malaria. Let them know early, let them know ahead of time, and tell them to spread the word to their friends and family. Why are we making these changes? The answer is drug resistance. Africa has had several waves of antimalarial drug resistance over the past 50 years, and a new one has arrived. Some of us remember how untreatable malaria was in the 1980s and 1990s. We are not going back to those times. We are preparing for this next wave of drug resistance by making sure the malaria parasite has many different drugs to fight. Our goal is to prevent drug resistance from becoming widespread. Is this approach strange or unusual? No. We're simply modernizing our public health systems to fight new threats. The best way to stay informed and to ask questions is directly through the website of the National Malaria Control Program or through colleagues working at the national program.
Merci à tous d'avoir suivi la vidéo animée Tête de cœur qui a globalement porté sur des messages essentiels à l'endroit où à l'attention des professionnels de lutte contre le paludisme. Et de façon générale, c'est une sensibilisation sur les nouvelles mesures qu'il va falloir adresser aux populations, à tous les acteurs, afin de prendre des mesures adéquates pour stopper ou alors pour freiner la résistance aux antipaludiques. Donc, sans plus tarder, nous allons passer la parole à professeur Wilfried Bankia, qui est le président de l'Institut Fomba, axé sur l'innovation, la science et la recherche, qui va nous parler de la résistance aux antipaludiques, mais plus précisément les réalités du Cameroun et les innovations à ce sujet. Professeur, vous avez la parole. Merci.
I hope that I can share my screen.
Yes, you can, Prof.
Okay. You see my screen?
Yes, Professor.
Okay. So thank you so much. And it's a pleasure that I'm sharing this for the second time in less than a few days. And I'm so happy that we're able to liaise with Dr. Bisong Itoe to be able to share this. You know, let me start off by saying that malaria still remains a major and leading cause of morbidity and mortality in Africa, especially because we are impoverished. So it's a disease that is linked to poverty. The second aspect that I'd like to bring up is that the greatest burden of disease lies in Africa, and that we know. 10 of the 11 most high burden countries are in Africa, and the other high burden country is India. Drug resistance is something that threatens the treatment success that we've seen in the past, control, especially for an efficient antimalarial drug or treatment. It is one that should provide lasting clinical efficacy. It is also one that should morbidity and one that should lessen disease. It's also one that should reduce the mothers go anemic, and it is minimize the risk and men should do. And as you know, chloroquine did that in the 60s, and currently the artemisinin combination therapies is almost akin to that of the therapies of the 60s. But we all know that those monotherapies, from the time of their determination in terms of efficacy, we all know that their efficacy has been dwindling. Chloroquine, by 1980s, chloroquine was nowhere. By the mid-1985s, quinine kept on going slowly down the drain, and now we find many pockets of quinine resistances, not to talk alone of mefloquine, was efficacious for a while, and then after that, it also dipped. All of these has made it very almost impossible, to the point where policy changes in 2000s, we globally accepted that the ACTs should be what is the medications of choice. But by the 2020s, we had also examined and noticed that the early artemisinin partial resistance was beginning to be signaled in many places in Africa. As you know, the greatest promoters of high burden of disease of this particular scourge, again, is the African countries. But then they have put up a number of principles to overcome the fact that they're high burden countries. Countries need to own their programs and lead their approaches. There needs to be a better coordination. There needs to be commitment, and there needs to be support and resource mobilization to be able to achieve the long-lasting gains. These are grouped into the impact that we need to have that are supported by these four major pillars, which are the political will, strategic information sharing, better guidance, and a coordinated response. Now, if we put all of this together, then we should see a reduction in the mortality and morbidity when it comes, therefore, to the approaches. These are the ACTs that currently the WHO has approved: artemether lumefantrine, artesunate amodiaquine, artesunate sulfadoxine pyrimethamine, artesunate mefloquine, dihydroartemisinin piperacin, and the latest gentleman on the block is artesunate pyronaridine, for which quite a number of trials were done here in Cameroon to establish its efficacy, but also safety against the liver disease. The case for ACTs was put forward and accepted because as a protozoan, it can multiply to enormous numbers in the system, and effectively for the medications to be effective, you need a combination of both treatment that is safe and rapid. And therefore, the artemisinin components was doing a rapid reduction in the parasite biomass, and that reduction in parasite biomass needs to be cleared off for the parasites that linger in the system with the accompanying drugs that have half-lives, as demonstrated on this chart. We know that by giving the accompanying drug alongside the artemisinin, a parasite should linger in its cycle that repeats every 48 hours, then it is possible for us to eliminate. And this is why the accompanying drugs were recommended to go alongside with the artemisinin for the treatment of malaria. We currently know that more than 651 million individuals in the rest of Africa are exposed to this. The question we should be asking is if the efficacy is at 95% and above, then there is a 5% of the population, or 34 million people, who are not responding to this drug. And therefore, the question is, what are they carrying? Is it the question of bioavailability, or is it a question of resistance, or is it a question of malabsorption? So whatever is the situation, 34 million people are not responding to this medication, and that should be scary. Now, what we see is a kaleidoscope of different countries using different formulations of the artemisinin combination therapies to effectively control malaria within their individuals, within their countries. Now, drug resistance has ensured. This drug resistance that has ensured is as a result of the fact that an effective drug that enters the system to the right and desired concentrations is not capable of clearing the parasites at that dose in which it is. At that point, you define something which is now called the resistance. And drug resistance has come about and is establishing itself in Africa. We now know that the resistance markers, the pressures from the different pressures of the drugs have defined it in such a way that chloroquine, by reason of its pressure, is mounting resistance at the level of about 30%, the antifolates at about 40%, the ACT partner drugs at about 20%, and the artemisinin mutations themselves are under pressure at about 10%. These different drug resistances have markers, which are genes that either transport the medication into the system, or markers which are enzymes that metabolize, or these markers, these gene markers, could just be, what makes the parasite itself move, like the propeller, the Kelch or propeller mutation. So chloroquine is a transporter, amodiaquine, it's a transporter, sulfadoxine and pyrimethamine are metabolism genes, and artemisinin is a propeller gene. So all of these are affecting the way in which the parasites would respond to the different medications. And mutations in these gene markers actually determine the extent to which the parasites can show resistances or not. We now know that in Cameroon, in the year 2000s, we could tell that exactly for 76T, which is a chloroquine gene marker, it was at 80%. That reduced with the withdrawal of chloroquine monotherapy to over 20%. That too, the marker for the multiple drug resistance gene 85Y descended from 70 to 25%. But the triple mutant for the PFDHFR gene went instead, and that's for the sulfadoxine-pyrimethamine, went instead from 40 to 85, and the PFDHPS, again, which is the gene for, sulfadoxine-pyrimethamine metabolism, or the folate metabolism, went again from 35 to 78%. So this has been the evolution in Cameroon. The pressure is on. But when you look at the artemisinin mutations, we haven't seen quite its establishment in Cameroon, but we have seen in other regions that in Rwanda, there was a particular gene codon that gave it its resistance. In Uganda, it was for the A675V and the C469Y. In Eritrea, it was R622I. In Tanzania, we're getting early signals. In the Horn of Africa, there's a rising vigilance in exactly what is being observed. Now, what effectively has happened is that, at least in Cameroon, we have stayed above the 90% threshold for which our ACTs can be efficient. So for AZAC and AL, over the years, we've stayed within 90 to 100%. But every time that we have a drop in efficacy from 100, we've also seen a rise in the prevalence of those molecular markers. And therefore, by use of those markers and by reason of the efficacy, we did establish something we now call the community sensor for the efficacy of these medications. And if you take AZAC, for example, you can virtually establish a straight line graph for which you can determine the presence of the mutant or the mutant gene, the prevalence of the mutant gene, and you can tell on the efficacy by extrapolating it onto the x-axis. So we have some measure by which we can quickly establish whether the mutations are causing resistances to levels which we should be concerned about their withdrawal. I bring you the picture of sulfadoxine-pyrimethamine or FANSIDA resistances across Africa. Now, there are 5 major variants. We have a southwest variant colored in yellow. We have a southeast variant colored principally in red. We have a northeast variant found in Ethiopia and some parts of Sudan, which we call colored in blue. We have the West African variants, which are principally green, but we have a Central African or Cameroon variant, which are midway between purple and a mixture of yellow and green. Now, we do not know exactly how those resistances in Africa are generated and how they move, but we know that the resistances are such that in the east of Africa, what would determine the protective efficacy of a single dose of SP has shown that it's not working as much as it should. But in Central and West Africa, this is still working. But the mutant that defines the quintuple mutation, or the 5 different gene alterations that should define resistance against the sulfadoxine-pyrimethamine, we don't find that in Central and West Africa because the 540E is not seen in Central and West Africa. However, there's a new mutation that is springing up, that is coming into being seen, and that's a 431, which Nigeria seems to be the epicenter. Cameroon has picked up that mutation, and we seem to see it also in Chad. Now, we're actively looking and investigating this 431V to find out exactly to the extent to which it can afford resistances against or resistance against sulfadoxine pyrimethamine. This is the situation currently in Africa. West Africa doesn't see it, and principally, we're beginning to pursue and follow up this particular mutation. But there's one other thing that I'd like to point out, that as the resistances began to appear for artemisinin, there was also something reported in Eritrea that both the artemisinin resistances and deletions of the HRP2 and HRP3 were seen at the same time. So the question is there some kind of a segregation of parasites that have these deletions and that also have resistances? We've seen those deletions also in Cameroon, but we do not see the presence of those mutations with it. So since mutations and resistances are a question of selection, we do not know exactly how this is going to play out, but we're actively on the field checking for what should be and is the current situation. So this is the story of the efficacy and how things have moved on. What do we need to do? ACTs are being used. Should we stay with the ACTs, or should we be able to look for ways in which we can mitigate this development of resistances by a clever use of ACTs and new other new interventions? You would hear that they have encouraged the has now encouraged most countries to enter multiple first-line therapies. Meanwhile, amodiaquine would drive it in another direction. So Cameroon, by reason of its error in 2006, having introduced artemether lumefantrine at the same time as artesunate amodiaquine, that was a mistake that became beneficial, because the introduction of both drugs, no matter the proportions in which they did distribute them, was actually protecting, each of them was protecting the other. And therefore, multiple first-line therapy is something which countries are now beginning to look at and embrace. And the idea is that it will reduce selective pressure on the parasites, it will slow down the spread of resistance, and it will preserve the efficacy of existing drugs. And there are many examples of multiple first-line. It could be that you use artemether lumefantrine in one district and artesunate. It could be that you use artesunate amodiaquine in another. It could be that you use dihydroartemisinin piperacin in a targeted group. It could be that you do a rotation. It could be that different segments are using different, public is using different thing from the private sector, idea of what its multiple first-line therapy should do. And they've gone in for a regional or zonal rotation. And this is what we would see happen in the next few years. The countries that are adopting this multiple first-line therapy as the frontline countries are Burkina Faso, Kenya, Nigeria, Tanzania, and of course, homeland Cameroon. And I'm sure that whatever we find in Cameroon would be applicable to most other countries, because we are known as Le Continent and we're Africa in miniature. The other thing that is becoming quite helpful are the monoclonal antibodies. These monoclonals are laboratory-made antibodies that can neutralize the parasites and block infection. There are many that have been developed, but they are capable of blocking passive protection for months, useful in infants, pregnant women, travelers, and seasonal peaks, where there are seasonal peaks. A single injection has an immediate action, and it can protect for a good season. They're fast acting, and the future as an annual or seasonal antibody injection in high-risk zone is feasible. The other thing I'd like to mention to you are the long-acting injectables. These are single-dose injectable medications or biologics which can prolong malaria infection for about 3 to 6 months. and better adherence than the daily tablets, and is ideal for children, especially where there's seasonal malaria areas. It could replace the monthly chemotherapy tablets in some settings. So long-acting injectables are becoming the investigations, once they're cleared through all the clinical trials. I think we'll start to see those very soon. Of course, there's the possibility that we could have an integrated strategy where we combine vaccines and we combine chemo prevention. And the example of those would be that we can take the RTSS vaccines or the R21, and we take the seasonal malaria chemo prevention. And it offers this dual layer protection and lowers the parasite load and will reduce mortality in children. This has been demonstrated in Burkina Faso and Mali, where the clinical trials showed a dramatic reduction in infant in the cases of deaths in these children, in the cases overall. And I think that reduction meant something which can help us exactly strategize in combining vaccines and the chemotherapy. This is something which we're trying to investigate here in Cameroon, which is effectively looking at what would be the optimal mix for evaluating the different interventions and to see what would prevent and protect the children from having the infection and from dying. And so this current project is on board, and we started with the ministry and with the National Malaria Control Program, working in Guinea and in Soa to determine what will be the optimal mix of this co-implementation of the strategies to combat mortality and morbidity in malaria. But then I bring you a slide which shows that clever thinking may end up, especially when these become available, that clever thinking may allow us to have the best innovations possible, and that will be by practicing precision prevention. Precision prevention. For example, in children under 5, we can decide to go for vaccines and seasonal malaria chemo prevention. In pregnant women, we can decide to go with monoclonals, but having an upgrade of the intermittent preventive therapy during pregnancy. In forest zones where the transmission of malaria is perennial, we can go for long-acting injectables, which give you a 3 to 6 months protective efficacy. If you go to high zones of high resistances, we can apply the multiple first-line therapies. And in situations where we have outbreaks, because sometimes you get these outbreaks, especially when they're preceded by floods, now we can go for rapid treatment and then add the antibodies. Now, when we do this, I think this precision prevention is the future of malaria control. Cameroon offers the best population possible to make this decisive contribution in malaria control, and the rest of the world could learn from us. I would like to thank you for your keen attention and all those who helped me in putting together these slides at the Fobang Institute, but also those who took part from the Multilateral Initiative on Malaria during the World Malaria Day webinar that took place on the 24th. On this note, I'd like to thank you for your keen attention. Over.
Thank you so much, Professor Mbacham, for this rich and insightful presentation. It was really great to listen to you. And now we have some few questions that were addressed to you, if you could answer to them. So we have Dr. Ngu Patrick that is asking, in the half-life on antimalarial drugs, he haven't seen proguanyl atobacone. This is the first question. Should I proceed with all the questions or one another?
Okay. You can take all the questions and then I can answer them in course.
Okay, thank you. So the second question is from Dr. Eko Filbert from Boya. He's asking, subtherapeutic dose of quinine is found in drinks sold in Cameroon. I know quinine is not used for malaria prevention. So what might be the reason, if not just the aroma, and the reason consequences of this practice?
Okay.
The third and last one is the chemotherapy and seasonal prevention. Is it possible in endemic equatorial zones? Can we be compared to Mali and Burkina Faso, which are not in the equatorial areas? Thank you.
Okay. Well, I think these are great questions. And yes, proguanil and atovaquone, they're not in the pipeline because these were also targeting the same genes to which resistance had been found. And I think for atovaquone or proguanil, even before they were used on the field, resistance had already emerged. So they're just not being encouraged to be used. Sometimes if you're going to some zones where there's no resistance, they might give you as a prophylaxis. But the unfortunate part of it was that by the time they were placed on the market to be marketed, there was resistance already that had developed. The second question from Boya came from Dr. Eko, who wanted to know whether the quinine that is in drinks might affect or promote resistance, or is it in these drinks for just the aroma? It is just for the aroma. The quantities of quinine that are in those drinks don't they're nothing. They're nothing actually. They're not even up to any dose that may affect a parasite. I think they're just in there for the taste and they're in there for the aroma. Now, the third question had to do with chemotherapy. Can this be used in the context, in our context in Cameroon, which is different from Burkina Faso and Mali, where the SMC is used? No, in the north of Cameroon, yes, you would have the seasonal malaria chemo prevention in the northern parts of Cameroon. But in the southern parts of Cameroon, it is not the seasonal malaria chemo prevention that's being practiced. It is the perennial malaria chemo prevention, which allows you to give 5 doses of sulfadoxine pyrimethamine that follow the vaccination cycles, but also at the distribution of vitamin A cycle through the expanded program on immunization. So it's the 5 doses. We did evaluate whether 8 doses against 5 doses was the most feasible, and there wasn't seemingly any major difference between the 8 and 5 doses of sulfadoxine pyrimethamine during for the perennial malaria chemo prevention. So the program currently is running a 5-dose program, and that's in the lower part of the country, in the southern part of the country where malaria prevention is perennial, and that's what is being used. And thank you all for your questions. I would stay on. If there are any more questions, I would take it all the way to the end. I will be on for the seminar until it's finished. So if there are any other questions, I'll take them at the general question and answer session. Thank you very much. And I hope that internet did not interrupt and that my presentation was smooth and understood.
Very insightful, Professor. Thank you so much. It's a great honor for us to have you join for this webinar. So I don't know if we have any other questions for Professor Bacha. You can raise your hand and we give you the floor before proceeding. Thank you. All right, let's proceed. Maybe after we have some question for Professor Bacha, and we take them as he will stay all along the webinar with us. So before proceeding, we want to introduce Dr. Jude Berenu, which is the Chief of Section Case Management of the National Malaria Program in Cameroon, to tell us a word before we proceed. Doctor, you have the floor, please.
Hello, thank you very much. Good evening to all. Can you get me, please?
Very well, Dr. Jude.
Okay, I'm trying to set my video, but I'll just go ahead. We will come on. I want to begin by thanking Prof for that wonderful presentation. Prof is somebody that I recognize very much, and there was no other person that could rightly present to us the presentation he just did, especially when we are talking of issues around addressing malaria drug resistance, which is, I would say, even though in Cameroon, when we look at ACTs, we don't yet have that very significant call for alarm, but as Prof mentioned, this webinar is reminding us, and I really want to appreciate the slide Prof presented, which guides the future. Precision prevention. That was a take-home slide that guides and really shapes interventions, and it takes actually into account the main element that we are addressing on this webinar, and also other aspects. So it cuts across not just prevention, but even case management. That I actually, because I'm head of case management at the National Malaria Control Program. So when it comes to drugs and the use of the different lines or the different regimens that we have, there is need to ensure that we guard and curb resistance. Even as we saw, some of the molecules that we have, we are already observing significant resistance. And when we look at the pressure that is being exerted on some of our key molecules, like our key regimens that are mostly used, chemical lumefantrine, more than, I would say, up to 80% of what is being used. Or when we look at our data, we notice that for treatment of simple malaria, 80% of the choice is on chemical lumefantrine. So Prof has set the stage, and the video that we also watch also informed us about the evolution of the landscape when it comes to resistance to anti-malaria. In this webinar, there is one important aspect that we also want to get, which as we're going ahead, we want to get the experience of the healthcare providers, those that are at the operational level, to share with us their experience, and why not their thoughts as far as this topic is concerned. So this is something that we are going to be seeing as we move ahead. So not to take much of a time, I just want to really appreciate Prof and to use the opportunity to table this worry that I have around MFT. Prof, you mentioned MFT implementation in high resistance zones. If we were to go operational, which method of implementation will you propose that we use in operationalizing the MFT? Thank you.
I think I would, okay, so basically the situation in Cameroon, for example, let me use Cameroon as our best example, is the fact that artemether lumefantrine is what is placed in the public domain in the north, so AL. And the reason for placing AL in the north is because they are using SPAQ as the seasonal malaria chemoprevention drugs. So you cannot place artesunate amodiaquine in the public domain where SPAQ is used in the north for seasonal chemoprevention. On the contrary, in the south, you're having a situation of perennial transmission, and therefore the public drug of choice is artesunate amodiaquine. Now, so already in the country, the north is using AL in the public domain and AZAC in the southern part of the country. Now, what the program was advised to do would be a rotation in such a way that when it now comes to, after 3 years, to follow the Global Fund rounds of implementation of funding, then AL will not be used in the north in the second round. Instead, another medication could be used. So it could be dihydroartemisinin piperacin, or it could be artesunate pyronaridine. And then in the south, again, a choice of either of these two will be used, such that after, in the third round, we do another rotation. And in that way, you're shifting the resistances being driven by these medications, and then the parasites would be fine. Let me tell you that something significant out of this mistaken policy of introducing those two when nobody was talking about MFT, it turns out that the parasites that originally were resistant to chloroquine, they're losing their resistanceness and they're becoming susceptible again because of that monotherapy. And in Cameroon, we're finding some kind of a stable situation. We're just like playing with these parasites, and I think we're on the good footing, which is why the program itself is so geared in taking this MFT forward, because we've seen the benefits even when we did not plan for it. Over.
Thank you so much, Professor Bacham, for your interventions that really enrich our dialogue of today. So we are going to continue with the second presentation of Dr. Yolande Fokam, which is a pediatrician consultant. Doctor, are you with us?
Yes, I am.
Okay, thank you. You have the floor.
Okay, thank you very much to give me the floor. Thank you very much. Good evening, everyone. I'm very pleased to be among this panel to give my small experience, my field experience, because that's the task that Dr. Itwe has assigned to me. When he contacted me, he said that he wants the field experience, that it should not be something theoretically with a PowerPoint. So I'm going to share it. I will first thank you, Professor Mbacham, for his presentation, which has reminded us a lot, and we have to do a lot to really avoid the extremes that even the coordinator of malaria program just listed. So just to set the decor of my presentation, I will narrate an experience of today when I was doing my OPD consultation at the Regional Hospital Boya. A mother entered with a child, a small girl of 2 years. She entered in my room, my consultation room, with a child of 2 years. with a cannula. So I gave her the seat and I asked, what's the problem? She said the child has started to have fever on Sunday. Today we are Tuesday, so it's just 2 days history. The child was having 38.5. She gave paracetamol. It didn't subside. She took the child to the nearby health center yesterday, Monday, around 7 a.m. and they run some tests. Among the tests, they were malaria parasite, which was positive. And yesterday, the temperature was 39, and they placed the cannula, and I saw in the book they started artesunate. Wow. So I asked her, so why are you here today in the regional hospital? She said, because the temperature did not subside. I was like, my God. I asked her to narrate me again the story. She said the same thing. I asked her, did the child vomited? She said no. Did the child had a running stomach? She said no. I was like, what was the indication of artesunate on this child? So just to set the decor, the topic that we are discussing today is of a great importance because we on the field, we are just mixing everything. And for sure, if we don't get up, we are going to lose a lot of things. Because if we have to put things in order, first of all, that child did not have no criteria to deserve an IV medication. Until they proved me the contrary, she was having simple malaria. And if she has simple malaria, when you give the drugs, you should explain to the parents that the temperature is not going to just disappear just by magic. It will take 24 hours, 48 hours, and sometimes 72 hours to have the apyrexia. So it's just a matter of reassure the parents. We should not rush to give injection, to mix everything. So that was just the history to enter in the debate. So the resistance is not something theoretically, it's clinically visible because obviously if we continue in that direction, we are going definitively to reach that extreme because the reasons are many. We have early or late treatment failure, we have frequent relapse in children sometimes, and we have sometimes persistent parasitemia beyond day 3, which sometimes can appear. So the key challenges on the ground, we are having several factors which can be accused for that. We have self-medication and inappropriate treatment, like just the case that I'm just stating. She didn't deserve any artesunate injectable. So we should really review who deserve what. What are the national guidelines? When do we classify as simple malaria and when do we classify as a severe malaria? And when we say simple malaria, what are the molecules that we are using? The another factors that we can have is use of monotherapy. Till now, we are still having some monotherapy available, especially the form in suppository, that we are seeing some children coming to our consultation after the mother has been prescribed some monotherapy as a suppository for malaria. We are also having poor adherence to treatment, and that is something that we, the clinician, we have to emphasize on it and encourage parents, I'm talking about my field especially, to explain to them that when we write a treatment, it's not because just the following day the child is active that they should stop. They should go till the end of the treatment. When a treatment is prescribed, the duration matter. It's not the number of tablet or not the number of bottle of syrup. It's about the duration which has been prescribed. Also, the variable drug quality. We are in a settle that we have drugs coming from everywhere, everywhere. So circulation of substandards of we may say falsified medicine, especially antimalarial drugs, we're having all type on the market, all type of malaria drugs from various origin. So how can we do about it? I think that one is not at my level, but something really has to be addressed because when you ask them, please, can you show me the packet of what you were taking? They are removing type of drugs that, in fact, We also have another factors on the field is the high transmission intensity according to where we are, the region, because we know that in Cameroon we have 3 phases of transmission of malaria in the same country. So also that variation from one region to another one can be also a challenge. Then delay care seeking in our settle also, it's also a problem. Most of the time when the children, they start to have fever, they start to have maybe stomach ache, you hear that they have gone to native doctor to treat ondabobi or konabele, those kind of things. So they come in a state where we are already facing complication. So those are the various challenges that we are having on the field, and what can we do? Because something has to be done. What are the practical action that we, the clinician on the field, what can we do? At the level of the clinician level, we must adhere strictly on national guidelines. Either we are working with the guidelines, either we are working on our own. ACT as first line therapy. We are still having some health center which are still prescribing quinine tablet, quinine syrup. I don't know if it is the fact that it is available in your center that you must sell it out, but we must work according to guidelines. If guidelines are there, it's because of it has shown some results. We should ensure correct dosing, and especially in pediatric. You should not see a child and just say, no, he look big, we should give 1/4 tablet, 3/4 tablet. No, with children, it's weight-based. You have to calculate, and the formula are standardized. If it is these drugs, you give this number of milligram per kilogram, and you see if it is suspension form or if it is tablet, which is adequate. And we should choose the appropriate galenic form according to the age and the capacity of a child. There are some big children who are not able to swallow tablet. So for them, either you choose something which is dispersible, either you explain to the parents that you will be forced to give suspension, but they will buy more bottle. So we should make sure about the correct dosing of what we are prescribing. Also, we should reassess. We should reassess our patient. When you prescribe a drugs for malaria, explain the evolution to parents, especially if we are thinking of simple malaria. Tell them that normally you should have apyrexia by this time. In fact, you should explain them the red flags. In case you have this, please to reconsult. We are going to revise and reevaluate the child and see if we are missing something. Just quietly like that. It's not a proof of weakness, because we know that even despite maybe a good treatment, you can, for any reason, the child can enter the phase of complication. Also, we may use appropriately our rapid diagnosis test or the microscopy before treatment. We shouldn't just assume that every fever because of endemicity is malaria. No, because sometimes we also are over-treating malaria. I think RDT is something available, and for children from 0 to 5 is free. So and it does not take it's just like the glycemia. So just a quick prick and you have the results within the next 10 minutes. So we should make use of the rapid diagnosis test if it is available, or the microscopy. I think even in category 6, at least microscopy before treatment is available. That is what I can say for the clinical level. At the level of the caregivers level, we should explain to them the importance of complete the treatment. If it's a treatment of 3 days, take it for 3 days. If we have started with injection, we should explain them that the relay is for this time, this length of time, and explain to them also the risk of self-medication. We should not relent our efforts to sensitize about self-medication, and this goes above the anti-malaria drugs. It goes for all drugs. Reduce the self-medication and remind also the responsibility of pharmacists, because the other point of acquiring all those drugs is at the level of pharmacy. The patient come, they explain, and they just sell the drugs, and they say, no, start with a malaria treatment, then if it is not okay, then go to the hospital. Why they don't send them first to the hospital before they coming back to them? Because definitively they are going to buy drugs. So if it is a problem of financial interest, they are not going to lose their customer. At the level of the prevention, I think a lot has already been done. The insecticide, mosquito net, the seasonal malaria chemo prevention, and latest we have the vaccines which till now in our area in Cameroon is not in all center. We still have some pilot zone. I hope that in the nearest future it will be extended to all the vaccination center so that we are really 100% about that other method of prevention. So that was what I can say concerning what we can do. Now, how do we limit the resistance progression? I think is by first eliminating the artemisinin-based monotherapy, because the more we are using monotherapy, the more we are going to face resistance. We should strengthen the pharmacovigilance and molecular surveillance in our country. We should combat, falsify, and unstandardized drugs because there are a lot, especially when it concerns to malaria. In fact, they are all type, all origin of anti-malaria drugs. And we should not relent effort to continuous training for healthcare workers, especially when it concerns to malaria in children. Because most of the disease in children, in pediatrics, they mimic malaria, but most of the time they are not also malaria. So we should train, continue to train, continue to do continuous medical education as we are doing it now for healthcare workers to tell them that when it comes to children, don't just focus, even if your MP or RDT is positive, check the ear, nose, throat, check the skin, check respiratory system, do everything before you remain with your diagnosis of malaria for children. So as a key take-home message for my experience on the field, I think anti-malaria resistance is not just a parasite problem. I think it's a health system, clinician, behavior, and educational challenge for us. And I think with all the efforts that we are doing, that the national program is doing, with all the actors in the field, every prescription matters, every informed caregivers matters. And I think if we join our hands, we are going to reduce the progression to the resistance of the ACT. Thank you very much.
Thank you very much, Dr. Fokam, for giving us the honor to present everything about the realities on the front line that you experience daily. And now we are going to give the floor to Dr. Jude for the panel discussion. He'll go to moderate the panel discussions. Dr. Jude, you have the floor.
Thank you very much. And we want to appreciate Dr. Yolan for the brilliant experience sharing, and we'll dive straight to the first set of our panel questions. But before we dive into that, I want to find out, do we have any questions in the chat? Ramla, are there any questions?
There
Yeah, maybe we
are
just take the questions before we come back.
there are two questions in the Q&A box. I don't know if you can see them, but the first question is, as we discuss resistance to artemisinin-based combination therapy, are we sufficiently treating it as only a parasitological phenomenon, or also as a social production of resistance shaped by health system access, informal drug markets, household treatment decision, and adherence behavior? And the second question in the Q&A box is, our current resistance surveillance system integrating social and behavioral indicators, such as patterns of adherence, treatment interruption, and household decision-making, or are they still focused mainly on molecular and clinical markers? Those are the two questions.
Okay. I think we want to invite, I believe those questions were addressed to the students. They did not precise, but
I think they were for Prof. Mbacham.
yes, Prof, are you with us?
Yes, I am. What's the question?
Okay, Masala, can you take the question that is addressed to Prof while we allow our Dr. Yolan and the others to have a break before we come back to the panel discussions? There were some
All
questions
right.
that were in the chat. Can you take it over for Prof?
All right, Prof. Mbacham, the first question is, as we discuss resistance to artemisinin-based combination therapy, are we sufficiently treating it as only a parasitological phenomenon or also as a social production of resistance shaped by health system? Second question, quite similar. Are current resistance surveillance systems integrating social and behavioral indicators such as patterns of adherence, treatment interruption, and household decision-making, or are they still focused mainly on molecular and clinical markets? And there's a third question, in the chat this time. Are there any data on the impact of HIV co-medication or an antiretroviral co-medication on malaria resistance? Over to you, Professor.
Beautiful. I think these questions have their place. I think the first two questions, the tie-in, I think Yolande did a wonderful summary, which demonstrated that we should go beyond the molecules and beyond the medications and the prescriptions because there are other contributing factors. Yes, behavior, the human factor is one of the most important because even after you've brought out the best medications and you've brought out the best procedures, if humans refuse to take them, you can't do otherwise. And sometimes it is our behavior that drives the resistances because once you give it and you don't give it at the optimal doses, then when the medications enters your body and begins to decline, when it attains its half-life and it's only in a little bit of an amount or less concentration than it should be, and you are beaten by a mosquito that's infectious, what gets into your system cannot be, what the parasites that get into your system cannot be eliminated by the drug that's in your system. And sometimes they are selected because they already show some amount of resistance, and this is what propagates the infection. I would take the question of if you have an HIV infection, your immune system is already compromised. Because of that system being compromised, the medications are no longer as effective as they would have been in a normal situation. So those who now get the infection help us select the resistant parasites because your immunity must work with the drugs for the parasites to be cleared. So the drug weakens the parasite and the immune system clears it. Now, let me give you a very simple example of dirty hands with grease, oil stain. If you go under the tap and you try to wash it, it doesn't get clean because water on grease just fall off. But if you take your hands and you dip them into powdered soap, again, they'll just stick to the grease. Nothing gets out. But if you combine the powdered soap and the water and you rinse off your hands, then the grease goes away. This is exactly how drugs and the immune system work. They work together, which is why when we have to test efficacy of antimalarial drugs, we don't go to adults. We go to young children whose immunity hasn't matured by the age of 5. So we go to the under 5s, and that's where we test for whether there's resistance or not. Because without the immunity, drugs can't play any major role. And therefore, in situations where the immune system itself is compromised, you get the situation of inefficacy of those drugs. Yes, the health system itself has helped us propagate some of these. Out of, I don't want to say inattention, of the system. I'll give you the great example. Hospital centers would survive in the past based on how much malaria they treated. And therefore, there was some income, there was some revenue. And medical doctors on this understand what I'm saying. Now, you come and you subsidize the medication and you send it to the hospitals, reducing some of the cost from 5,000 to 500 or 200 francs. That's fine. The medications have been subsidized. But the hospital centers don't have money anymore to function. What do? When the patient appears in front of the medical doctor, he tells the patient, hey, your health is my concern and you are my responsibility. Therefore, I tell you, you need a drip. Drips are not subsidized. So people pay for the drips, the hospitals get in the money, and they're able to function. And therefore, in 2012, 2014, we published a paper which showed that we could effectively help the population by subsidizing the health centers to function. If you subsidize antimalarial medications, you should subsidize the health centers. Now, this is a policy decision, which I think when I become a politician, now I'm not, when I become a politician, I will champion this to make sure that if you do subsidies for medication, you must also subsidize the functioning of the hospitals. Otherwise, they will go back to their old systems of telling the patients you need a drip, and then you pay for the drip. More expensive, but it lets the hospital function. The last aspect I want to bring, which Professor Dorothy Njoma, every time I come out to talk about malaria, she pulls my ear at the end. You didn't talk about the environment. The environment is very, very important, that we must take care of the environment. Otherwise, we cannot take care. If you're solving the problem by treating the symptoms, then what causes those symptoms? You cannot survive it. So while we say people should sleep under bed nets, we should take their medications, we should take care of the environment so that the mosquitoes do not breed in those environmental standing water. Remember that the mosquito that transmits malaria is a very clean mosquito. It doesn't like dirty water. So it stays in very clean water. That's where they breed. If you carry water and stand it in a vase and put flowers inside, I bet you in 2 weeks you'd see larvae, pulsating everywhere around. So you should frequently throw it, otherwise they'll develop into mosquitoes. And you say, but I lock my doors. Where is the mosquitoes biting me from? It's from the flower vases in which you've put in clean water. It's from the water pots where you've reserved water for the dry period, dry season. Once those water pots are not covered and have stayed open for a long period, they bring in the mosquitoes, they lay their eggs, the larvae develop, and then you get transmission inside the house without you even knowing that that's what you're doing. I think this is where I'll stop so far.
Okay.
Thank you.
Thank you very much, Prof. We'll now move on. Ramla, over to you.
Oh, you have the floor, Dr. Jude. Go ahead. Thank you.
Okay, so at this juncture, we want to listen to address some, some direct questions to our panelists. This will actually enable us to, pop in more into what we have been discussing. So we have a series of questions that we want to address to our panelists. And the first is on sharing experience with the use and misuse of anti-malaria regimens, that is especially the ACTs and the ACTs, including the injectables, in management of malaria in the health facility. And at this point, we'll listen to, I think Dr. Yolande in her presentation mentioned, but we still want to, first of all, give her the floor to address this, while we'll also be introducing Dr. Zona. Dr. Zona is an internist still from the Southwest, who is also going to come on board, but we'll begin with Dr. Yulan. Dr. Yulan, if you're with us, over.
Dr. Joe, can you hear me? Sorry for interrupting.
Yes, Dr. Bison.
Okay, thank you. Just to give input, I'm just suggesting that since Dr. Yolande mentioned most of the aspects, or generally in her presentation, and we don't also know how much time we might have, is it possible to start with Dr. Zuna and then she might come in to complete or ask some questions? That's the first suggestion. And also from the slides, if you look at the questions, the three sets of questions, I don't know if it's possible to just ask the three question one so that when the person takes the floor, they can free flow and answer them because the questions are somehow interrelated. Just a suggestion.
Okay, so thank you. The second question is, what are some of the factors that you have observed leading to anti-malaria drug resistance from your experience as a healthcare worker, mentor, and in your community? And the third, what should healthcare providers do differently in the health facility and community to prevent anti-malaria drug resistance? Dr. Yolan, you can begin. Thank you.
Okay, thank you very much to give me back the floor. And as Dr. Itwe Bison said, even without seeing all those discussion questions, I think I've gone through the experience with the misuse injectable. I think the recent one was the one of today, because that child definitively, she didn't deserve any artesunate injectable. She was not presenting any signs of severity of her malaria, so it was really not appropriate for her to use it. And as I said at the end of my speech, when I came in from the first time, the anti-malarial resistance, and I think Prof reiterate it, we are the people promoting it. It's not even the parasite which is resisting to the drugs. It's we that we are in fact, over treating, over prescribing, misprescription, unnecessary prescription, inappropriate prescription, inadequate galenic form, especially when it comes to children. So we really have to continue continuous medical education of ourselves. We can do in services presentation, like we can say that every 2 months or every month or every 2 months, we take a malaria case that has presented to us in the unit or in the hospital, and we do a review, because we have the feeling that we know malaria, but every time you see that when you are having a case, especially when it comes to complication, that we don't know malaria as we are pretending. So it will not be a weakness that if in our various place of working, we say that every 2 months we should present a case of malaria, because malaria has now a multifaceted presentation that is not the one that was writing in books. So that's what I can say to answer this question. Thank you.
Thank you very much, Dr. Yolan. Before we move to the next set of questions, Dr. Ito, as the regional coordinator of the regional technical group for the fight against malaria, you supervise, or you mentor and follow up what is happening at the operational level. We have gotten the experience from the health facilities. We would like to also get on your view with respect to these 3 questions. Given your experience and following up what is happening in the health facilities directly. Thank you, and over to you.
Thank you very much, Dr. Berenui. So, first of all, as a clinician also, I want to just start the way, let me just copy from Dr. Yolan. When a lecturer speaks, you have to learn from the lecturer. When I started working as the coordinator, the best thing about my practice is I continued volunteering in hospitals for about 2 years, trying to implement the guidelines to see if guidelines work. Because I myself, when I was still a clinician, used to be very skeptical about the guidelines. And that permitted me to really apply the test and treat approach and work closely with collaborators or colleagues to ensure that we respect what is mentioned in the guidelines. We suspect only those that with the case definition test only suspected is most value treats only confirmed cases. Of course, there was a lot of resistance from most of the colleagues, and that same resistance is still seen when we go down to the field. Before saying what I really think, I just want to recount what I tell healthcare workers, because some healthcare workers present here. One challenge that we have that might also promote overuse of these anti-malarials and even also leads to drug resistance is treating with negative tests. We have situations where people don't test and treat. Some people decide to come to the health facility because they want to be treated for what they really have. Surprisingly, we have a very high tendency of healthcare workers doubting negative, particularly negative RDTs. And all of us know that these tests are highly sensitive and highly specific. Even though there is risk of false negatives or false positives, it's a bit low. So that's the first question that I have. As healthcare workers, we doubt negative tests. Even the microscopy comes negative without it. No, it has to be malaria. The rapid diagnostic comes, it has to be malaria. But also as a coordinator, I've never observed a healthcare worker who doubts a positive test. That's the irony. Because if you're doubting a negative RDT, you should be able to also doubt that, maybe this RDT also is positive. But nobody doubts a positive test. They only doubt a negative test. So my first thing is, for the patients that have come to the hospital, have entrusted their hands in us, benefited from testing, we still have many healthcare workers who doubt negative tests and continue to treat the other main pathology and also add an anti-malaria. And you will see that sometimes, because the patient did not have malaria, let's say somebody that has arthritis sometimes, for example, and you end up testing them, once you give their anti-inflammatory and start feeling better, the chances are they are not going to continue taking their anti-malarials. And all of us know that suboptimal doses, once you take a treatment only for 1 day instead of a full 3-day course, it promotes drug resistance. So that's the first thing that I have to say from operational level. Another operational challenge, Dr. Jude, that I also want maybe Dr. Fush, Dr. Yaran, and Prof to share their views here is we have this idea of schools, boarding schools in particular, who request that their students, whether or not they have symptoms, should go and do tests. That you need to show proof of anti-malaria test and treatment before coming to the school. It's common in many boarding schools. And being in an endemic zone, these students present themselves to healthcare workers, and the healthcare workers ask me that, what do I do? They need this from the child to go back to the field. And you know that if students who are going back to school regularly go for testing, because we're in an endemic zone, also because we still have challenges in our microscopic diagnosis, we still have assurance where lots of false positives. For example, there is a high chance that there might be a false positive test, or because we're in an endemic zone, they might have some parasites in their blood. They will be given treatment, and since they're generally not sick, the adherence to this treatment is very poor. So that's first thing. People coming to request for testing are benefiting from treatment since they are not sick. Well, people do not adhere well to treatment, and that also goes a long way to promote drug resistance. In a large scale also, the next the next thing that I've observed, excuse me. So those are two things that I've mentioned for now. I'm just looking at the table because we have some time. These are the two main things that we have that I think that really go a long way to promote drug resistance. But also as a healthcare worker who has gone on as a regional coordinator who goes around supervising healthcare workers, observing the way they manage. The key aspect of that I also observed that can really promote drug resistance in our context. Let me start by saying that it promotes treatment failure in our context is poor adherence. Observation is that the poor adherence is mostly because of poor provider behavioral communication. We still at this age have healthcare workers who unfortunately say, mom, take your medications, go and buy and drink, without emphasizing on the effectiveness of the medication, without emphasizing on the need to respect the dose, without emphasizing on the need to buy the medication from the right source. Even the disadvantages of not respecting the dose, not respecting the right source or the dosage. So those are some of the operational challenges that we are facing. There are still more. If time permits, we can come back. But I really want to have the point of view of maybe the permanent secretary or even you, Dr. Jude, and even Prof, on this aspect of students, boarding schools, pushing their students to go. And not even point of view. I just want to also get your own contribution because I know what we should do. But what's your take on it also, where the schools are pushing to the healthcare workers? And Dr. Yolande also, what can you say to other young healthcare workers who are tempted to want to say that, the school has requested, let's go ahead and test and treat? Thank you. Over for now.
Thank you very much, Dr. Bisong. We are actually looking at the time also. We will have to also consider the time, but you have raised some very pertinent issues, which at this point, the permanent secretary is with us. Ramla, do we listen to the permanent secretary now or we continue
All right.
at the end? Thank you.
All right, Dr. Ju, thank you very much for moderating the panel discussion. So it's great to hear that we have the permanent secretary of the National Malaria Program here with us. So we are going to invite Dr. Zemeka for a speech for the issue about malaria drug resistance in Cameroon. Dr. Z, are you with us, please?
Then we had one more panel list of questions there for the civil society organization, just to remind. I know that the time is short, but maybe in one word, so help us.
All right, for the last question. Okay,
yes,
go ahead, Dr. Jude.
Yes, Ramla, I think we'll just rapidly conclude the panel discussion section. Coming back to Dr. Eto, you raised some very pertinent issues with respect to students, and I'll link it with this the fourth question that which is coming from what Dr. Fokam said. I think the main thing here is respecting the guidelines. Dr. Fokam, Yolande emphasize on the aspect of respecting the guidelines. And we recently revised the guideline in I would say recent, well, it was in 2024. And it's true that we have had a delay in actually making the hard copies of these guidelines available to the facilities. We are working on that, but we had actually sent out the soft copy versions, and it was a question of disseminating it while we are actually producing the hard copies, which will be sent. Because in everything we do, we need to, first of all, be informed of what are the norms, what are we supposed to do, what is supposed to be done. And even when we have students that are present, they are there to learn. The first thing that they are supposed to know when it comes to malaria case management is that there is a guideline. I remember when I was in med school, we used to call guidelines, they are like, in quotes, the Bible. When you reach the hospital, you have guidelines for each management of each pathology, which you had to really master. So if we respect the guideline, be us the nurse that is at the OPD, or the medical doctor that is prescribing and all of that will be going a long way to actually curb developing or progression of resistance, because there will be no need. And it will help us when we want to communicate, because there are some of the issues that we are raising which have to do with communication or behavioral change. But you don't communicate when you don't have the fact or the facts from the guidelines from the documents or guide. That's what should the population know. And also, just to add that we are also working on some short messages that are tailored to the community. I think within the context of the universal health coverage and free malaria treatment, I think in the course of the discussion, Prof mentioned and also Dr. Yolan mentioned, but we'll have another webinar when we are going to discuss free malaria treatment, because it has actually come up. We will have to continue to sensitize. We'll have to continue to sensitize, especially free malaria treatment for below 5 years. There are many interventions that are in that package that the government has actually put in place. And at times, because of ignorance or because of, people want to, healthcare providers, they want to make some extra money and all of that. They don't actually respect the guidelines or some of these policies. So I think we'll have another discussion around that in one of our webinars. But I just wanted to emphasize on the fact that the guidelines are there. They are there for us to actually follow and reduce some of these issues that we are addressing. Now, coming back to, we have the next series of questions which are actually addressed to the ISA team. I'll just read the question. The first one is, as a civil society organization, what community factors and behaviors have you observed that promote anti-malaria drug resistance? And the second, what can civil society organizations do differently to prevent anti-malaria drug resistance from a community perspective? And are there any other experience to share from, operational perspective or from what you have been doing in line with the topic that we are discussing? Thank you.
Thank you so much, Dr. Jude. The question addressed to Isa, is it from the Q&A or the chat box?
No, there are questions for the panelists. I think are you getting me, please?
Yes, I'm getting you now. All right.
Okay. So the question is actually addressed to
any civil society organization from the field, but
I'm not seeing Madam Shangela. Dr. Bisong, it seems she is connected.
No, I am there. Ramla, we wanted one civil society organization from your side that you work with, or even one member of ISA, to just give more insights on what role the civil society can play and do differently in also accelerating this fight.
All right. Thank you for the question. Okay, we are going to provide the answers on the chat and we'll proceed with the webinar accordingly. So for now, we are going to present the Protect the Cure documentary and present the recommendation of the Protect the Cure initiative, which is highlighted through the documentary. Thank you. So I'm going to present the Protect the Cure documentary here. So the Protect the Cure documentary was produced in collaboration with the Boni Lab at Temple University and Normal Life. It's a 4-part documentary titled Protect the Cure, and with Impact Santé, Impact Santé is working with the producers for getting the target for the awareness about the problem of drug resistance. So the film is divided in 4 parts. We have the context. The chapter 1 is presenting the understanding of the rise of resistance and its global implications. We have the problem, the resistance to artemisinin, because one of the factors of resistance is because people are not taking the drugs as they are supposed to take. And we have also people that are medicating themselves. They don't do, for example, tests to be sure that they are positive of malaria before taking drugs. So we have also in the documentary the aspect of patient's perspective, stories from communities on the front line. So how resistance to artemisinin-based therapies are treating decades of progress since 20 years. And the last one is the solution, the urgent action needed to protect the cure and to preserve the efficacy of treatment. So through the stories of scientists, the voice of experts, the films is aiming to raise awareness about the problem of drug resistance in Africa. So after that, as part of the Protect the Cure initiative, Impact Santé Afrique did several consultations with multiple stakeholders. And during those consultations, we gathered some key recommendations from those dialogues that we are going to present right now. So those recommendations, we are just going to present some few, and you have the access to all the recommendations. We give you the link via the chat. You can click and have access of all the recommendations there. So we have strengthening surveillance and anticipation of resistance, which is establishing and strengthening national and regional epidemiologic surveillance system for antimalarial drug resistance, ensure early detection of resistance markers in order to rapidly adapt treatment policies and protocols, promote cross-border data information sharing, recognizing that resistance know no borders, develop regional collective surveillance mechanisms to enable a coordinated and effective response, act proactively and in alignment with the international standards. So here we mean to adopt a proactive approach without waiting the widespread of drug resistance, align national strategies with the WHO recommendations and the most scientific evidences, integrate resistance containment into long public health. So you have the access to all these recommendations. It's more than 2 recommendations. We have at least 7 or 8 recommendations that we gathered from strategic consultations that we had before in the process of the activity of Protect the Cure. So we put the link on the chat and you have access to it. Thank you. So now I think that we are getting at the end of this webinar, and I really thank all of you for your participation. It's really enriched the webinar. We were very grateful to have all of you here, and you really did this webinar particular with all your intervention. Thank you to Professor Basham for his insightful presentations. I want to thank also Dr. Ito Besong for his collaboration and for letting this webinar being done today. I also want to thank the regional delegate of public health that is here, Dr. Ambe Leon, which will conclude the webinar. And
Hello.
yes, Dr. Besson.
Hello, Ramla. I'm sorry for coming in or barging in. We have some pertinent questions or comments in the chat that it will not be good that we conclude without getting Prof actually address. If Prof is okay, I will read them, and before we will listen to the regional delegates that we have connected. There was also another issue that Dr. Yolande raised, which I'll also want to get the views of the two regional delegates before we go. I know that we are already 3 minutes above time, but can we actually go ahead with the questions?
All right.
Okay.
You have the floor, Doctor.
So thank you. The first question that was from an anonymous attendee, not anonymous, actually. High regards to all panelists, especially Professor Bacham. I am Dr. Solem, a hematologist. My question concerns malaria-induced hypersplenism, in which patients almost always test negative to routine assay. But a 1-month treatment always relieves the symptoms. Please, are there any national guidelines for treatment and management of such cases? I think this one is addressed to the National Malaria Control Program. Then, when we are coming back to this, let me read the other. Okay, another question is, are current resistance surveillance systems integrating social and behavioral indicators such as patterns of adherence, treatment interruption, and household decision-making? Or are they still focused mainly on molecular and clinical markers? Then we also have yeah, so these are the two questions that we have from the chat. And then there was also one that Dr. Yolande raised with respect to what can be done to curb the circulation of certain, substandard medications that we have. This is where I actually wanted to get the views of regional delegates that are with us, because we know that from the ministry right down to the regional level, we have structures that have been put in place to actually control this. So we'll first of all listen to Prof, and then we'll come back. Thank you, Prof. Over.
Okay. Thank you very much, Dr. Berengi. Thank you very much, Yolande. I think let me start with the question that was asked by Dr. Iko Philbert in Boya. He asked whether the subtherapeutic dose of quinine found in drinks sold in Cameroon, and he knows that quinine is used for malaria prevention. The question is, does this have any consequences on resistance? The answer is emphatically no, because the amounts of quinine that are found in those drinks, like in Schweppes, it's just for the bitter taste and the flavor. Nothing else. It's not in any doses that can affect anything. I think by the time you even drink it, except you want to tell me that you want to sit down and drink 1 crate or 2 crates of Schweppes tonic, which is not the case. So in the doses in by the volume of what you consume. It has no consequence, actually, has nothing to do with the resistance that you find. I'd like to answer the other questions about current patterns. I think we did understand that human behavior mattered. We responded to that, and that it's not just the prescription and the intake, it's also how we treat, how we respond to what it is. And all fevers are not malaria. And so I think Dr. Yolande Fokam and Bering also insisted when they spoke that all fever you must test, and Dr. Itwe Besong said you must test and then treat. And then, of course, the program will track. So test, treat, and track. So you must be able to test. This in particular, testing, I had to fight with my wife for quite a while to let her know that all the fevers that they were having at home may not be malaria fevers. I brought in a rapid diagnostic test. It took them a lot of convincing, but when they finally realized that they didn't test positive, they had to believe in the test. And when my two daughters finally graduated from medical school, there were those that now took on that advocacy job. Substandard drugs that are in circulation, it's an issue. I remember 22 years ago when we went out to look at what were the medications that were sold and whether they had the active ingredients. I don't want to tell you by what proportions those that were tested had. And some just were just cassava with a flavor. There was no active ingredient whatsoever in those. How do we stop this in circulation? It's difficult to know, it's difficult to say how to stop this. I remember when Jude was still in school in Bamenda, when he was vying for his degree in health economics. There was a study that we conducted in Bamenda with patent medicine dealerships. And there were patent medicine dealerships that existed. When we took a rendezvous to come back the next day, those stores were shut down overnight and they disappeared. But again, you'd find patent medicine dealerships dealing directly with the medical doctors themselves in the hospital. And here in Yaoundé, where you don't have a lot of those patent medicine dealerships, you hide the roadsides ambulatory traders who are always concentrated around hospitals, pharmacies, or schools. Now, don't ask me why these targeted areas, but they go to these areas because of the population and because sometimes, even for the ambulatory vendors, they are doing so to liquidate medications that are about to be cleared out of the pharmacies. So everybody is guilty of promoting this whole thing about non-responsiveness of parasites to our medications. If you go to the central market in Yaoundé, there are three sectors in the central market. The top floor of the central market has three sectors. Drugs that are sold illegally from China, India, Indian subcontinent. You have those that are sold illegally from the European continent and those that are sold illegally from the West African drug market. So basically, again, I'm not calling any names of people or where these countries, these drugs come from, but you have this. And systematically, it's almost impossible to shut down those things. There have been mixed forces, gendarmes, police, the law enforcement officers, and the regulators. They have gone many times to the central market to shut this thing down. But every time they go there, they get some high calls up from people and they withdraw within 5 hours of intervening. So it's a mixed problem that is ingrained into our society. I do not know exactly how we can tackle this, but it's an issue that must continuously be debated, put out in the public, and maybe someday there will be some force that takes them away from selling these illicit drugs. So they are in circulation. I can tell you that there are 92 varieties of ACTs that are being sold illegally on the streets. 92 varieties of ACTs. Now think about that. Most of these don't have the active ingredient, and there's just the flavor. So what are we doing to ourselves? So when they tell you there are street drugs and there are drugs on the street, so these are two different categories of drugs. Sometimes it's a messy situation, but let's continue debating about what to do and how to get these drugs off our streets. With the issue of spleen, the splenism, you would find it in certain situations. Medical doctors, you know that this is what they also tell me, that when you're palpating, you palpate also to find out if the spleen is swollen. If the spleen is swollen, then it's likely that you want to place the patient on a medication that's repeated after a month. So you treat now and then you treat later on, you treat after a month, so that that can be taken care of. Doctors, don't forget to know how you were taught to diagnose malaria. It's not just by simple questioning, because from that you can find out whether they had a history of repeated fevers every 2 days. And then you have to examine the patients. There are many signs and symptoms on how you must palpate the spleen to find out exactly if the spleen is swollen. So I can go on and on and on and on, but remember that you were taught in school in exactly how to diagnose for malaria. Don't forget that diagnosis and rush people to RDTs or to microscopy. Still examine the patients physically and then proceed to your prescriptions. Thank you very much, and I think I have addressed all the things that I was asked to do.
Okay. Thank you very much, Prof, for the response. We have the regional delegates. Ramla, I'll hand over to you to continue with the moderation, but I'll love to get their opinion on the second to the last point that I think Prof already provided some elements of response, but as regulators of health activities or health-related activities in the regions, and this phenomenon of circulating anti-malaria drugs that are substandard and that are actually promoting this drug resistant issue that we are discussing. I would really love to get the opinion of the public health delegates of that we have the privilege to have them on this webinar. Thank you. Maybe we'll begin with Dr. Eku, who has been very active in the chat. Thank you. Hello, Dr. Eku, you wanted to say something?
According to the agenda, because Ramla passed the floor to me for the closing remarks, so that's why I was speaking. Because she passed the floor, so I see Albert's not take her on. It looks like the SP is back, so I wanted him to give his general appraiser before we go now to the two delegates giving their closing, because this has to be an operational. We are giving the delegates to close because the fight against anti-malaria drug resistance is more regulatory, more operational than it is even policy, because we have the right policy only. So if the permanent secretary is there, permit us hear from him, his general appraiser. Then we give the floor to Dr. Ambe, Lionel. Then after Dr. Ambe, Lionel for closing remarks, partial closing remarks. Then Dr. Eko Filbert also would give his own partial closing remarks for us to call it a day. I just see a hand there. Albert's not take her up, so I think that should be the permanent secretary. Sir, you have the floor. If not, we'll give the floor to Dr. Ambe, Lionel.
Dr. Eto, there is Dr. Boy. There is Dr. Boy Halmut. That is the person whose hand is raised.
Ah, okay. But for time constraints, I think if you write in the chat, you can reply in the chat. But we give the floor to Dr. Ambe, Lionel, the regional delegate of public health from the Northwest. Sir, we really appreciate you mobilizing actors from the Northwest and joining this call. The Malaria Pills webinar series, ISA, we appreciate your stay and the National Malaria Control Program. So you have the floor. After you, your colleague and big brother, Dr. Eko Filbert, will just round off with the closing. Having in mind what Dr. Jude also asked. You have the floor, sir, Dr. Ambe.
Thank you very much, Dr. Itwe, for giving me the floor. I really want to appreciate this, what you've done with respect to the webinar on malaria resistance in Cameroon. I would really want to start first by really extending my sincere appreciation to our distinguished presenters and the panelists for this highly insightful webinar on malaria resistance. In particular to Prof. Bacham, Dr. Fokam. At least when Dr. Fokam presented, I was really reassured, because sometimes we have an impression that the clinicians have abandoned us, and also to Dr. Jude and yourself and Ramla. So basically the contributions were very rich, and we saw that they were grounded in both scientific evidence and much more operational realities. And I believe that they have greatly enhanced all of us here present, our understanding on the evolving challenges in malaria control, particularly in the context of resistance and treatment practices. So as we conclude this important exchange, there is really one message that stands out, that malaria resistance is no longer a distant scientific concern. It is now an operational reality confronting health workers daily across Cameroon. From our health facilities to community settings, the way malaria is diagnosed, treated, and monitored is directly shaping the trajectory of resistance. So this being we must be frank about these challenges, and I'm glad that you have raised it up very well. Too often, malaria is treated without confirmation. It's a battle that we have been fighting. Despite the constant availability of the rapid diagnostic test, we still have cases that we see being treated like that. We continually see a particular kind of diagnosis that we don't know where it usually comes from, poorly treated severe malaria. And sometimes it's an element of trust in the system, where a facility treats malaria, it goes to another facility, the facility considers that malaria was not well treated, and they have to treat again with the same molecule. So this inappropriate and abusive use of anti-malaria undermines its clinical effectiveness and can possibly accelerate resistance. We need to understand that these practices are not isolated. They reflect most often a broader systemic problem that has to do with the supply chains, ensuring that the commodities are always available, continuous supervision, especially from the region and the program, and sometimes even on the pressures that the patients put on the providers. I have malaria, give me medicine. I have malaria, I want the artesunate injectable. And then most particularly, the self-medication in the community. And to conclude with what Dr. Jude said, the question that was addressed to us, the circulation of substandard and counterfeit anti-malarials. That is a battle that we are fighting. I think Professor Bacham really earmarked already most of what we are doing concerning that. But of recent, today, you can see that the minister signed a letter to really restrict the flow of medications through the roads. Now it's either it is through ship, maritime, or by air. I think this measure is greatly going to limit. When I saw that note, I immediately forward to my custom and the central police commissioner to know that when they see any vehicle now with medication inside, they have to really check. So all these, as we see, really contribute to the dangerous cycle that weakens our ability to control malaria effectively. Nonetheless, the good thing is that pharmacovigilance is picking up in the regions, in our regions, and we have pharmacovigilance focal persons at all levels, the regional level, the district level, the health facilities level. But we still have the weakness that most adverse events of medications are not being reported. Sometimes treatment failures are not being reported. And when we have signals, they are not often being investigated. So pharmacovigilance is not just for specialists. It is a responsibility for all of us, especially the prescribers that are here, the dispensers, and the health facilities. And I believe that when we adhere to these pharmacovigilance principles, we are going to be able to identify some very key and pertinent issues Quite often in my committee, I've seen people coming with research that they want to test the effectiveness of anti-malaria. Then I ask them this question: can you justify? Is there any problem? Anything has been reported? They say, no, we just want to see. I say, it doesn't come like that. We have to monitor first. And if something is reported, then we investigate further. So moving forward, I think at the end of this workshop, this webinar, we must really recommit to some very few principles, especially the frontline healthcare providers that are here with us, that we must test before we treat. No diagnosis means no anti-malaria, and we have to strictly adhere to the national malaria treatment guidelines. We have been doing a lot of trainings and refresher. We must also promote the rational use of medicines at all levels. And more importantly, we have to strengthen pharmacovigilance, our reporting and feedback systems, and we must engage our communities to reduce self-medication and misuse of anti-malaria medication. We need to understand that resistance most of the time is not driven just by the parasites, but by practices. And therefore, we can contain resistance if we improve on our practices. So basically, I thank everybody for their commitments.
Thank you for all the intervention. So now we call Dr. Ambe, the Regional Delegate of Public Health.
Ramla,
Yes.
sorry for cutting you. You had Dr. Ambe already gave his closing remark. So at this point, we are just to thank all those who participated. I see most of the participants have already dropped. So we are already at the end. Maybe Dr. Eto, you have some announcements for us, or Dr. Ramla?
Thank you very much. Just to say that we will continue in the same light. We really thank ISA for the collaboration. We note that most of the frontline healthcare workers still have challenges connecting to Zoom, Ramla, so we should take that into consideration and maybe share a small video to guide them next time. The malaria pills webinar series, this is not the first time, Prof. We're having meetings on a monthly basis, and the idea is to tackle the guidelines one problem at a time. And according to our schedule, the next topic that we have is on the free treatment policy, because the policy exists, but we still have many challenges. We are hoping that we are going to collaborate with Impact Santé in the nearest future again to organize more webinars, particularly even on advocacy and more tutorial engagement. We also have that one in our pipeline. And Professor Mbachan, thank you for listening to our call. When it arises, we always love having you as our father. So thank you very much for joining. Thank you, Ramla. Thank you, everyone. It was a pleasure, and especially thank you, our regional delegates, for this wonderful session. If Ramla has any announcements, she can give it. If not, I think that Dr. Ambe already concluded the session for us. Thank you, and over.
So thank you once more. Thank you, Dr. Bushman, for the collaboration of the webinar. Thank you, everyone, for your participation, for engaging during this webinar. And we look forward to organizing more webinars to talk about other issues or to engage more or raise awareness about the question of the resistance. Thank you and good evening to all of you.